transitioning with epilepsy. It's a really crucial topic for a lot of people with epilepsy. My name's Elizabeth Weil. I work with the Epilepsy Foundation, Eastern Pennsylvania, as the Camp Transitions and Hispanic Services Coordinator. So a piece of my job is working with families and transition age individuals to connect them with a lot of the non-medical supports. We also have some medical professionals here who are going to delve into the mechanisms of transition on the medical side, but we really want to provide you with a chance to ask your questions.
Kind of what we had planned to do to just start it off is, because we're all from different systems, and Carly and I work with the adult population and Sarah works with the pediatric population, we thought that Sarah could start by talking about how early to discuss transition, things to do while still with the pediatric provider, and then I'm going to talk about actually making the jump from pediatric to adult provider, and then Carly will talk a little bit about moving through adult care. And then Elizabeth will be here to discuss resources and things like that through the Epilepsy Foundation for the transition ages.
All right, so when we talk about transition, we normally start around age 12, which kind of sounds early. We're not kicking you out by any means, but we're just trying to get you to be more independent. So at age 12, your kids should really start learning their medications, why they're on these particular medications. They should know their allergies. And then they should start practicing taking their medications on their own, maybe filling up their own daily med trays, and then practice with them. I mean, you can observe them, but then after a while, you shouldn't have to be reminding them to take their medications. They should be able to take it on their own. 12 and up, just kind of start practicing. It's really important that they wear either a medical bracelet, necklace, or have a medical ID card in their wallet. A lot of phones now have an emergency medical button that they can press and enter in all their information, just in case something were to happen if you're not with them. And then especially for epilepsy patients, if they have a rescue medication, it's really important that they have a buddy with them or tell their friends oh, hey, this is where I keep my rescue medication, wherever it is. If it's clonazepam tablet, oh, here is where I keep it in my purse at all times. Or if they have a VNS magnet, let your friends know where the magnet is on you so that they can help you in case of an emergency and their parents aren't there. And then it's also really important for 12 and up to start asking questions at their own doctor's appointments. You're the patient, so any questions, we really want the patient to be talking and not kind of the parent taking control of the conversation. You might be asked to step out, and then the physician will talk to your child alone. I think that's it. Did I miss anything? Those are the big kind of things, just becoming more independent, taking your medications on your own, and then knowing the names of your medications and doses are a big thing, because I always, when kids come into the office, I'm like, okay, what medications do you take? And half the time they can't tell me, and by age 12, I always ask them what they're taking. So just getting in that practice and knowing what doses they're taking too is really big.
So then I guess to move into the transition piece, the first question we always get is, when is the right time to transition? So that answer is really different between patients. So not everybody is ready to transition at the same time. There's been lots of studies done on this to see, do you kick them out at 18 across the board? Is that, the hard line? Some people say yes, a lot of people say no. And then other things like college, do you keep them through college to get them through that with the same provider and then, boot them out over that? And I don't think that there's one standard answer for that. So some people, they hit 18 and they're ready and they don't want to sit in a waiting room where there's bubbles blowing and babies rocking and things like that, and they want to come out and they're ready for that. Whereas others, they don't want to leave that comfort zone quite yet, so it's not the right time. And so the age is not really as important. The important thing is to have a plan. So like Sarah was talking about, building up this confidence that somebody can start to think about managing their own care as early as 12 years old. So then it's not a question as they hit 18, or some cases they hit 20 20 or 22 or 25, and they're still going to their pediatric provider, and then they get the shock when they say, you can't come back here anymore. So you never want this to be a surprise. Adolescence in epilepsy, this is a time frame where everything's changing, both medically, developmentally, like Dr. Jensen was talking about, socially, and so you don't want to throw any other challenges into the mix. So our goal is to kind of make this as smooth as possible. And so some things, once you are ready to transition, the things that I want to talk about is what to do for that very first appointment. Because that first appointment with an adult provider is really important. And we hear a lot, a patient will go and see an adult provider and completely freak out and be back at their pediatric provider for the next visit. And that's a failure of the system. And so things that we're trying to work on is, I think number one is setting an expectation. If somebody follows you or your children from the time that they were born to the time that they were 18 or 20 or 25, there's no way that somebody who's meeting you for the first time is going to be able to encompass all of those things. So being prepared for that and to have the first visit really be a learning experience to get to know each other. Because you need to get to know the provider and the team and the system of the new place, and the provider likewise needs to get to know you and the system, the family system structure that you have. And so along with that, it's really important to provide records ahead of time. So, a new patient visit is much more manageable if somebody has a heads up of what's coming. So we usually request records at the time that you make your appointment, so that way people have time to review all of the history before you come and meet us. Because it makes your time more valuable while we're sitting in front of you. And then to also understand that it's important to transition all care from pediatric to adult providers at the same time. So again, it's like one smooth process. So a lot of what we do is try to coordinate people who have multiple medical providers in the pediatric world, whether that is a psychiatrist, whether that's a primary care doctor, and they're still seeing a pediatrician. We try to kind of understand all of those needs and coordinate that off the bat. And then I guess the last piece of it is really having an expectation at the end of the first visit as to what the follow-up is. Because adult follow-up and adult coordination is a little bit different than what you see in the pediatric setting. A lot of the pediatric neurologists, they're very comfortable with mom, dad, freak out, send me an email, I'll email you back at 2:00 in the morning. And then you go to see an adult provider and they're like, my email address, you don't get that. And so, it's different, but it's just the differences between an adult provider and a pediatric provider. And if you as a parent or as a patient understand that from the get-go at visit 1, then the transition will go a lot smoother than if you have different expectations and then you leave the visit and you're at home and you're like, well, I had this question I'm trying to call and I'm not understanding why I can't get the answers that I want right now. And so knowing how the system works is really important before you leave that visit.
So transitioning from pediatrics to adult epilepsy care requires the patient or your child to become more active in their own health and to play a more active role in their health and their epilepsy. Most important, I think, is that they know they know what they're allergic to. They know if they're being treated for any other health conditions. They know what their past medical history is. They know what pharmacies they want medications sent to. These is conversations to have before the visit, questions that we will ask. Like Sarah was saying, during most visits, I will ask to see the patient alone. Parents, family members, could you leave the room, wait in the waiting room? No offense to the family members, this is routine across all healthcare in the nation. This gives the patient an opportunity to ask the questions that they might be embarrassed to ask, or ask the questions that their friends might be thinking. This is all confidential. We can't go back and squeal to the family members. So something to be aware of. It's important and it's nice if you bring a notebook or something to take notes with, because the doctor may go and give you orders and give you prescriptions and give you medication instructions to write that stuff down. It's also nice if you bring a list of any questions that you've had. When you think of something at home, write the question down, bring the notebook with you, so then you make sure all your questions get answered. Another important thing, probably the most important aspect of the visit, is that the patient knows how often they're having seizures, to be able to track their seizures. You should also tell them what their seizures look like, describe so that they are able to describe to the doctor what their seizures are like. An easy way to do this is a seizure calendar. Do the old-fashioned way, get a calendar, put it on the refrigerator. Every time you have a seizure, mark it on the calendar, bring the calendar in with you. There's also an app for that now. The Epilepsy Foundation has the My Seizure Diary. I actually downloaded it myself. It is very easy to use, very straightforward, but very thorough. You bring that with you, and then the doctor is able to look at it and see exactly how often and what type of seizures you're having.
Thank you. So the Epilepsy Foundation, our role in this is really to be your partner. So the medical piece is really important, and when you have questions that maybe you don't have time to get answered at your doctor's appointment, that's where we come in. But we also recognize that there is a lot more to transition than just the healthcare. A child is going to be going from the education system into post-secondary education, into a vocational track. They're going to be working on independent living. They're going to be working on so many different things that are important. I put together a handout which gives a lot of good tools for this process. Some of the things that we do is we have a camp program. At our camp program, kids are having that time to be away from their parents for the first time, to discuss having epilepsy with their peers, which is a good time to start learning, how do I disclose? When do I disclose? Because that becomes very important in college and in your job eventually. When you're a kid, most of the disclosure happens automatically. You get accommodations because you have epilepsy. Those accommodations still exist once you leave kind of the comfort of the childhood system. However, your role in it has to be much more proactive. So we work with individuals to help them feel comfortable and help them feel comfortable choosing to disclose or not to disclose and who to disclose to. We also have a young adult retreat which goes through a lot of those same things, and so that's for the 18 to 30 crowd to have a chance to come together and talk about a lot of those issues. How do I talk to my doctor? How do I talk to my employer? How do I talk to my girlfriend, my boyfriend? How do I access transportation? It's a very complicated issue, as many of you are aware, but starting at a young age, Sarah mentioned starting to think about healthcare transition from age 12. We recommend that all transition planning, you start thinking about it as young as age 12, because it's going to creep up, and what we don't want to see is an individual at 18, 20, 25 all of a sudden saying, oh no, I have to scramble, I have to figure out what I'm going to do next. So to start thinking and to realize that you are very capable. Epilepsy is just one little piece of what you have, but there are tons of tools out there to help you navigate that process and to be as independent as you can be. So our goal really is to let you guys ask questions. So, I don't know, did anybody write any questions down, or do you just want to go for it? Okay, we can just go for it. Sure.
All right, thank you. I have a question on the ask. Hey, no, Carla.
Hi.
But, I have repetitive seizures. They're usually complex partial onsets or partial onsets. Now, is there any, I have a great job right now, which, I love, but is there anywhere where I can go on the internet and see, what certain job aspects are meant for epilepsy patients with certain conditions, and be able to know, I don't ever plan on losing my job, but I get cautious about that. Would there be anywhere I could go to see what job recommendations would be for that person?
And so one great resource is the Job Accommodations Network, JAN, and that is on the sheet that I gave you. And that has some really good tips for people with epilepsy about what accommodations might work for them. And I think that helps you try to think about the types of jobs that you can look for. Are there other sites that you guys would recommend?
That's a good one.
I think that's it's very thorough.
Thank you.
Do you have any sort of big ticket items that you would be able to offer as far as what to look for in a transition, either emotionally or, I don't know, medically is probably kind of a crapshoot, but I mean, ours is obviously not at that age yet, but there's a lot of concern of, I go from being like, live in the moment, to my kid's gonna be self-medicating at 12 and the whole thing's gonna fall apart. And it's really difficult for me preparing for that transition. Preparing for the transition. Is there anything that you can?
I think, honestly, the fact, how old is your child?
He's
7. And so the fact that your child is so young and you're already having those feelings to process through yourself is already half the battle. Because the people who have the hardest time are the people who don't think like that, who don't think that their child's ever going to be self-medicating until, it's tomorrow, and then, they're behind the 8 ball. It's kind of the natural progression of change. And so realizing that things are going to be different and that your child is going to be, to the best of their ability, the most independent that they can be, and, somewhat self-sufficient at some point, is a huge realization for you as the parent to kind of let that go. As far as transition readiness, there are 2 very different transition readinesses. There's transition readiness of the patient and there's transition readiness of the parent, right? And they don't happen at the same time either. But so things to look for in your child when the time comes to gauge if they're ready is if they're answering the questions in the appointment. If they're comfortable in the appointment, at some point when Sarah over at CHOP says, "Mom, step out, please." There are 2 ways that can go, I'm pretty sure. One is the patient is ready and talking about things, whether it's, their medication management or whether it's just openness and talking about their questions and things like that. Or they can absolutely shut down and be like, nothing. And so I would say that's why we started early, and that's like a huge piece of readiness. If they're comfortable in the appointment, that's just one example, but across the board, if they feel comfortable with that. And then they'll probably start to bring you along with that eventually, right? So the more comfortable that you see your child being, the more comfortable that you'll be. Okay, he can actually do this, and then you'll start to be calm with that. And, talking to the adult team, that's definitely possible before you make that jump. Or a lot of times what people will do is they'll go for the initial visit with the adult provider and they'll already have another last appointment with their pediatric provider like a month after that, just to be like, okay, we did this. This is where things are going. I wanted to kind of full circle back. And then you feel more comfortable moving forward, and having a point person. So more than half my job with this transition program is being that point person. So when the physician's not being the most responsive person, or when you feel like I can't really tell the physician that I hate the physician, or there's something that's going on there, it's nice to have a point person that you can go to. And so identifying that person no matter where you go is really important in helping you feel better about it.
Thank you.
Anyone want to add?
Yeah, you had mentioned, meeting with the patient individually and, asking the parent to step out. How exactly do you, because in the keynote address, there was the mention of, possibility of cognitive limitations and, there could be an issue of brain injury or whatever. How do you incorporate, I'm sure you still have that one-on-one time with the patient, but how do you then coordinate or collaborate with the family with someone who might not be the best historian or a source of information?
So typically we get the bulk of the information, especially when it comes to epilepsy. A lot of patients don't know when their seizures are happening. They're not aware if they have a seizure. Most of that information comes from the witness, right. Someone who sees the seizures, of any family member. The reason we ask the parents to leave the room is because that's when the patient is able to discuss any questions they might be having about problems at school, social interaction, stuff like that they might not want to feel comfortable asking in front of their family members. But I would say that the bulk of the seizures and that talk is done with the family member in the room, because most patients aren't aware when they're having seizures unless somebody tells them so.
Thank you.
This is more like half question, half comment related to the pediatric neurologist and adult neurologist. Now, I've had epilepsy since the age of 12, and like for insurance purposes, when I was 20, I was referred to a pediatric neurologist. I'm not sure why, being an adult at the age of 20, it was actually Dr. Berkovitz, and I saw her for 3 years. At the age of 23, she said, I have to go into my study, and you're too old to keep seeing me. And then I was transferred to Dr. Ney down at Jefferson. But I wasn't really freaked out at all when I switched from the childhood to the adult neurologist, and she's been helping me a lot for the continuous years up until this point. I don't know if that's really a question, but I don't know why the heck or why in the world they would refer me to a pediatric neurologist at the age of 20. My dad, my father said maybe they didn't know where else to send me at that time with my insurance. Now I have my own insurance that I'm disabled and I'm not in school and college anymore, but at the time I was in college, I was attempting it, had to stop going because of my severe learning disability, but she got me tested for that and everything. She was great about that. She said, I want to get you tested for a learning disability because I was really having trouble, really struggling in my classes, lectures with epilepsy when I was in my college years. So, I don't know, that was under his insurance, I think it was like Keystone Health Plan, because I was in school, I was still able to be covered under his.
It was probably the college thing. So usually, if you haven't been anywhere and you're in that gray area, sometimes people will, if you're school age, send you to a pediatric provider. I've seen it.
Gray area.
So that
was 2 years.
So the gray transition area, when you talk about transition, is somewhere between age 17 and actually age 26, is where we see people still hanging out with pediatric providers, and technically into adulthood.
Yeah, because I felt so strange and funny, in the waiting room with a bunch of kids, and I was, 20, 21 years old, but that's the reason why?
Probably.
Yeah.
So, I could explain that to him when I...
Yeah. I don't know if it's a more new policy that's come about, but if someone's 18, we can't accept you as a patient. If you've never been seen at CHOP before, we'll send you straight to adult care now. So if that would have happened now.
Going back almost 20 years ago, but they have changed since then.
Yep.
When did they change? Just curiosity.
As long as I've been there, so that's only 2.5 years.
Oh, okay.
So
it's been way beyond when I.
Yeah, so and especially because I think transition's something that's being talked about a lot more now, and it wasn't so much back then. That kind of sounds like what Bethany was saying, was during college. I mean, either one's fine to see a pediatric. I mean, we still have so many kids through college at CHOP versus
I didn't know
we
that.
do. So if we follow
I never
you,
used to see any other ones that looked around my age.
yeah.
In the waiting room. Oh, but they did. But we mean back then, but no longer. But back.
No, we still will, because as Bethany was saying, the transition age is 17 to. Yeah, so until we can get you transitioned over. Yep.
Okay, I'm glad I got that answer after all these years.
Yeah, so it's definitely it's kind of a hot topic now, and there's definitely been more research. There's more advocacy and more details of how to go about transitioning now than there probably was 20 years ago. So now we have more resources too for it. Yeah.
Yeah.
Yes.
Can epilepsy cause MS?
No.
And,
Yep.
it's SUDEP. Is the main cause of SUDEP having a seizure while you're sleeping?
There's an association there.
There's an association, but I wouldn't say the main cause of SUDEP. There's no cause. There's no specific cause. The main cause of SUDEP is having a seizure.
Just have a seizure, right?
Right.
And you can have it while you're awake, basically any time of day, and it can happen. Right?
Yes. So the main ways that they kind of recommend to prevent your risk of SUDEP is taking your medication on time, avoiding things that you know are triggers for you, getting enough sleep, avoiding alcohol, just doing whatever you can to manage your epilepsy to the best of the ability that exists within the epilepsy community. So if you're in a situation and your medication isn't working, that's, for you, and you're still having a significant number of seizures, that's when you're talking with your providers about what other options exist for me.
Okay, yeah, because I forget what I was going to say.
Okay, that's okay.
On the extreme other end of the spectrum, where you have someone who's transitioning who's really just not capable of much of anything, which is kind of where we are. I mean, she walks and talks and functions somewhat, but she can't do anything alone. At what point and how do you start looking at the possibility of the only solution, or the best solution, being a facility? I mean, because I'm not there, but I can see that may go there, because at the moment we're trying to transition her into the community, which is of course the state mandate. But you get into the simple administratives of, here's a really good day program. Now, my daughter, for example, has a nurse, private duty nurse, 12 hours a day. And my nurses don't really even like it when I'm not there, because it's so hard. So she really needs 2 people, is the point, but she has 1. So to take her to a day program, well, the day program can't do any trips with the nurse because there isn't room. So the point is integrating her into the community. It's just not that simple. Now, we're hammering through it as best we can, but at what point do you look at a facility? What facilities are really good to look at, and who helps you with that? Because the state doesn't want to help you because they don't want to write the check. So how do you, that's like social worker, who?
Right.
I mean, that's not a pretty road, but unfortunately it's a real road. I'm not getting younger.
Right, you're not getting younger, and what I generally recommend in those cases is not to wait until it's a situation where you can't do it anymore and no supports have been set up.
That's kind of where we're headed.
So does she have waiver services?
In New Jersey, well, we just she's not on the community care waiver.
Okay.
She was on the MLTSS waiver, and that eliminated her from anything social. So she's actually the 3rd child in the state of New Jersey, because I've screened for 15 months, to go into the Supports Plus program, where she now we buy the nursing.
Okay.
But really nobody knows how that program works anywhere.
Yeah, and unfortunately each state is a little different. But what I would recommend is getting a good, what they're called supports coordinators.
Well, I have one of
So
those.
if you have a supports
But
coordinator.
she's ready to bang her head against the wall too, because
Okay.
it's a lot. You know what I mean? It's not, she can't go anywhere without a nurse. And
Right.
anyway,
Right.
it's just a road. You know what I'm saying?
It's a road, and it's a very challenging road. But it sounds like you're making the right steps. We're in a situation now where, yes, the government is saying to us, community integration needs to be the standard.
Right.
However, we do need to provide supports for people who need more help than what kind of the current idea of community integration looks like. And I believe that we will tackle those challenges, but it's kind of a step-by-step process. If you're, my general recommendation is that, the supports coordinators are the ones that are really tied into it, and getting as much, figuring out, maybe is there a different waiver that she should be on, and applying for that now, so that because there are waiting lists. And
Well, she's on the CCW waiting list.
Okay.
Because my husband and I are over the age of 55.
Right.
But my husband's like 70. So I'm not feeling well. I've got medical issues. So now I'm getting very concerned, because there's nobody that can deal with this. There's no there's no sibling, there's nobody that can.
Right, so you're looking at a situation. And this is something, I mean, I think it's probably more of a one-on-one conversation. I'd be happy to talk with you more about some of the programs that are out there.
But who helps you, like, in other words, who begins to make that call? Is it the neurologist?
No.
No. Okay.
I think it's a team decision. I mean,
I think the main decision is the family and how the family's comfort level. Yes.
Yeah, and you're going to have to look at so many more factors than just the medical piece.
Right.
So that's why it's not just the neurologist making that
Right.
recommendation.
What facilities? I mean, I was actually told by a special needs attorney that really, even though I live in New Jersey, I live in Cape May County, so it's like barren. There are no services in Cape May County, New Jersey. It's the most underserviced county in the state, in fact. But what kinds of facilities in the region? I was told really, is there Melmark in Berwyn?
There's a lot of different.
Center in Langhorne are reputedly the best.
I mean, I think it depends what you're looking for.
Quality of life.
So yes, quality of life, but there's some programs that are larger, some programs that are smaller, some provide more, you're looking for very specific nursing care. So
No, I'm looking for quality of life.
quality of life, yes, but
we have nurses, but they don't even, some nurses are afraid to take her for a walk. Like I'm on duty all day to come and retrieve them when they go down somewhere. She's not really that welcome in a yoga class. The instructor is a doll, but people don't want to see a grand mal seizure. And my kid lives on the edge of a grand mal seizure every minute.
Right. And that's where sometimes the education can come in, and that the foundation could come into some of these programs that your daughter's involved in. And you're in New Jersey, so we'd have to go with the New Jersey affiliate for this. But we could come in and provide seizure first aid training so people don't feel as overwhelmed. And it's a step-by-step process trying to encourage people to realize that a seizure is not an immediate medical emergency, that if you take the appropriate steps, the person will be fine. This is especially for your daughter, someone who has epilepsy, this is a normal everyday part of their life, and with the appropriate supports, you don't have to necessarily be calling mom or calling 911
Right.
for every event that occurs.
Well, they don't. I mean, they're just, it's intimidating.
It is. It can be very intimidating. So increasing their comfort level is something that can be helpful in that situation.
The person I wanted to say about what you said, what's your name?
Elizabeth.
Elizabeth. The person will be fine. They're having a seizure as long as they're not driving
Well.
behind the wheel.
Yes, you do run into
Because I
those.
just had a seizure in March. I was in an allergist's office. My neurologist said to me, scary to me. Thank God I wasn't driving because I got, time being, my license suspended because of the seizure. I've had a few. But she said to me, scary to me, like, God only knows what would have happened to me if I had that seizure while I was driving. I might not be alive right now.
Yes, you bring up a very good point.
So you'll be
So-
okay as long as you're not driving.
Yes.
Yes.
I think we probably need to wrap up. Any last questions? You ask this woman?
A granddaughter that has
Sure.
epilepsy. And, she's 11, so 12 is a good point for us. But, some of the milestones that she'll be reaching, like driving.
Mm-hmm.
Are there limitations to people for driving?
So you live in New Jersey, so it's in Pennsylvania. You have to be 6 months seizure free.
It's the same in New Jersey.
And it's the same in New Jersey. Okay, that's what they used to have a longer.
Yeah, I think
Yeah.
it's the same.
Okay. So they used to. So you have to be 6 months seizure free to be able to be eligible for your license.
How do they measure that? For her, we don't see seizures anymore.
Right. So it's the physician reports that. So if
It's-
she's controlled on medication, then you shouldn't have a problem. But if she is still having seizures, the neurologist is the one that is the mandated reporter for that.
It's the neurologist call. Yeah.
All right, thank you very much. If you want to come down, we'll answer your questions.